So it's an extreme honor and privilege to introduce our friend and colleague, Matt Carlson, who is at Mayo Clinic. Matt did his residency at Mayo Clinic and then did a fellowship at Vanderbilt, and then now is back at Mayo running their acoustic neural program, publishing proficiently. And so it gives us a wonderful opportunity to welcome him to the House Series lecture. He's going to talk about the prevalence and natural history of vestibular schwannomas. So Matt, thank you very much, and thank you for joining us.
Thanks a lot. It's a huge pleasure. And like you said, we normally get to interact, all of us, 2 or 3 times a year in person, and it's something I've really missed quite a bit. It's the main thing I like about meetings, candidly, more so than actually getting more new information. So I'm very grateful to have the opportunity just to present this way. Let me make sure I can share screen here. Right. And so a lot of what I'm going to be talking about is the epidemiology and trends and what the direction of the field seems to be going in. But overarchingly, I want to present some ideas that I think we present, or we think of as dogma, that might not be accurate, or it might have changed enough. So I think we need to change the way we're thinking and we frame a lot of these things. And so I'm going to present some things that everybody might disagree with in some stances. I do have data to support my opinions, but I think it's something to think about nonetheless. So I've titled this Rethinking Vestibular Schwannoma. And this is a book that we've worked on, and many of you are contributed to book chapters in this also. So a lot of this is in there. Just to give you some background, Rochester is located in southeastern Minnesota. It's kind of where the plains meet the bluff country. Rochester itself has about Olmsted County has about 160,000 people, and about 30% of people in Olmsted County are connected to healthcare in their job. And so it's a very medically literate population, which will come into play a little bit later when we talk about some of the epidemiological studies that I'll present. So southern Minnesota is more of the plains and bluff country. Northern Minnesota is a different area. It's much more a treed area, a lot more forest. So we'll often go up there for vacationing, kind of 2 different areas. This is our primary team for caring for patients with vestibular schwannoma. And I would say that our NF2 team, our core team, is much more expanded than this. We have about 20 providers that are regularly involved in NF2. But when we talk about just about patients with sporadic vestibular schwannoma, this is the core team, 3 neurotologists and 2 neurosurgeons that we interact with on a daily basis. We see almost all of our patients together in the same clinic. So the patient will come to the room, we'll review the images ahead of time, and then we'll both go in and talk to the patient to give our impressions and jointly arrive at a decision with regard to care pathway. Just some background about the Mayo Clinic. I'm a big history buff, or I guess you could say history nerd is probably a better way to say it. And so I look back in our archives for a lot of different things, but I look back at our vestibular schwannoma history, and the first surgical description of what seemed to be a vestibular schwannoma was in 1907 at Mayo. We had the 3rd gamma knife unit installed in the US, and we always had a strong collaboration between otolaryngology and neurosurgery, which is something pioneered by the House group. I don't think anybody would dispute that. It has its legacy there with Hitzelberger and House. We manage about 200 new vestibular schwannomas each year. This is kind of an interesting, just going back to some of my interest in history, this is not the earliest operative note, but it is one of the earlier operative notes, and I think it's kind of interesting to, let me see if I can. So if you look at this history note, this is, I think, from the 1930s, but it basically allows you to see how far we've come. We almost look back at people and what they did 100 years ago as very primitive and almost barbaric. And I think that in 100 years, people will think the same about us. We'll probably have a pill to take care of these or something, but still, we're still operating, and we're still using radiosurgery. But this operative note describes how the surgeons basically became increasingly frustrated because the patient who was having the surgery for a vestibular schwannoma under local wasn't holding still enough, which is something funny, I think, to even imagine doing a vestibular schwannoma microsurgery on somebody who is awake. So broadly, we're going to talk about epidemiology, natural history, treatment, quality of life, and we'll have some side tangent thoughts and discussion along the way. So I'm going to present some ideas that we commonly think of as dogma, and I want to challenge those as we go through this. So doc, how common are these? Well, when a patient comes in, they say, you know what, I realize I've just been diagnosed with a vestibular schwannoma. How frequent is this? How unlucky am I? And we'll often say, well, it's 1 in 100,000 people get these. And that statement is wrong on many levels, and I'll describe why, but it's basically what's, very commonly told to patients. So getting into that statement, you have to get into incidence and prevalence. Incidence is the number of new cases within a population that are diagnosed during a certain period of time, versus prevalence are all the people within the population cross-sectionally at that time that have it. So it includes people who were diagnosed 10 years ago and are still are continuing to observe their tumor, or somebody who had radiosurgery 10 years ago and still retain their tumor. The only cure for a vestibular schwannoma is gross total resection, where it's actually gone. So it's the only way you can drop out of prevalence technically. And so when a patient asks the question, how common are these, or what are the chances that I would get this in my lifetime, they're really asking prevalence, but the 1 in 100,000 is incidence data. And it's actually very old incidence data additionally. So this is a study that we did, an epidemiological study that looked at the incidence and prevalence of vestibular schwannoma in Olmsted County. So again, going back to that healthcare literate idea, this is definitely a selected population. Probably people in Olmsted County are a little more likely to see a physician than someone else in Wyoming or something like that. And so there is selection bias to it, and we do have a large number of MRI scanners. So that also probably influences our data, but still interesting nonetheless. There's very few data sets in the United States that you can capture essentially everybody with a certain condition within the population. The REP, the Rochester Epidemiology Project, was conceived in 1966 by a neurologist, and it basically links all of the healthcare records in all of Olmsted County. So even if you're not seen at the Mayo Clinics, like if you're seen at Olmsted Medical Center or another private practice group or something, essentially it has a 99.9% capture rate, and it's been validated in over 3,000 different studies. So we think the data is pretty accurate. So if you look at the incidence, the number of new cases per given time in the population over time from 1966 to present, you would see that the age-adjusted incidence is actually right now is closer to 4 or 5 per 100,000 people per year. So already 5 times that antiquated or old data that we'd say of 1 per 100,000 people per year, which is more of a 1970s or 1980s incidence, pre-MRI era. But then if you look at adjusted incidence according to decade of life, you can see that there's a spike in the patients that are between the ages of 50 and 70 with an age-adjusted incidence per 100,000 people of up to 10 per 100,000 people per year. So all of a sudden we're 10 times what our previous quotes were. But the better story is what's happening now, and not, a lot of those changes are washed out when you average it over 50 years. When you look at just the last 10 years, and you look at people between the ages of 50 and 70, the adjusted incidence is closer to 25 per 100,000 people per year. So that's 25 times the rate that we would commonly quote to patients, but that's incidence. And so now if you look at the increased frequency and you look at it more from a prevalence standpoint, which is really what the patient is asking, the lifetime prevalence of acquiring a vestibular schwannoma, if you live long enough, is 1 in 500. Which technically renders it no longer a rare disease by most definitions in the United States and other countries. 1 in about 2,000 adults will acquire a vestibular schwannoma, and 1 in 500. And this is clinical, so these are diagnosed. These aren't autopsy studies that were done a long time ago in a selected temporal bone series, which we've commonly seen having high incidence and prevalence. These are people who are alive who are diagnosed with vestibular schwannomas. Your lifetime prevalence, if you live long enough, exceeds 1 in 500. So not nearly as rare as we thought before. And we've just seen, this is not, I think that might be a little more novel. This is not novel. And we've seen it time and time again, particularly from the Copenhagen, Denmark data, that patients are becoming slightly older at the time of diagnosis, and they have less symptoms at time of diagnosis, and the average tumor size has decreased over time. Intuitively, we always say that the reason more tumors are being the incidence and the increasing prevalence is not because we think there's a true biological shift. We just think we're getting better at detecting them. And that's primarily because there's more MRI scanners, they have better resolution, and we also have adopted screening protocols for sudden and asymmetrical hearing loss better than we have in the past. And that's probably true. That's probably 99% of the story. But we looked at that. So we looked at in the Olmsted County Medical Center, in the Rochester Epidemiology Project, we've looked at the incidence of head MRIs that were obtained and the incidence of new diagnoses. And if the increasing incidence and prevalence are caused by a greater access to MRI, the two should parallel each other pretty closely. But what we find, so this is the incidence of head MRIs per 100,000 people per year within Olmsted County. You can see there's a relative plateau around 2003. So after 2003, there weren't more head MRIs being performed each year. But when you look at the rising incidence of vestibular schwannomas, the inflection point's actually around circa 2008 or 2009. So we're actually seeing a disproportionately larger increase in vestibular schwannomas than what we would predict based on just MRI. And so maybe that suggests perhaps there might be more than just MRI access or something else driving the change. And actually, technically right now, so if you read textbooks, they'll say otosclerosis is the most common cause of acquired hearing loss in the United States. And that was true a while ago. It's no longer probably true. And if you, in Olmsted County at least, you're more likely to be diagnosed with a vestibular schwannoma than otosclerosis. And this is not people referred into Olmsted County, because you could say, well, this has changed by your referral patterns. No, these are people that reside and live in Olmsted County. And so I think this is very remarkable. And you'd say, well, how could this even be? It doesn't really make a lot of sense. But I just remind you that this happens all the time. We're just not used to thinking about it this way. But like, for example, HPV positive oropharyngeal carcinoma has resulted in a significant epidemiological change in that disease in the recent years. And so it's not surprising that we couldn't see something in vestibular schwannoma also. It's also, like we've already talked about, I think everybody would undisputably agree that the incidence of otosclerosis has dramatically decreased over time. In the era when people were doing 200 surgeries or 400 surgeries for otosclerosis a year, that's changed. Nobody's really doing that many anymore. So just some key points from the first chapter of this talk. 1 in 2,000 adults are diagnosed with a vestibular schwannoma. And if you live over 70, your lifetime prevalence, your lifetime risk is over 1 in 500. They're diagnosed at smaller size in older patients with fewer symptoms. And we might actually be witnessing a true biological shift beyond just enhanced disease detection. So now let's talk about the natural history, another very interesting topic. So I think all of us are acquainted with the data from Denmark, Copenhagen, Denmark, which I think it was 1975 or 1976, they've been cataloging all of their tumors. All of their tumors have to be managed within a single center in Copenhagen, Denmark. So they essentially capture the whole population. There is no referral bias or selection bias. Everybody diagnosed supposedly comes to the center. And so it gives you very, very clean data. The problem with their data, and it is the biggest series that's out there right now, they just published a series with almost 4,000 patients being observed, so large numbers. But there's two problems with their study and how we can apply it to us. The first is their definition of growth for IEC tumors. So they don't count growth of an IEC tumor until it expands into the CPA. So if you have a 2 millimeter IEC tumor, it can grow up to a centimeter, or even some IECs, you can grow up to 1.2 centimeters, and it still won't be counted as growth in their series. But by our standards, we'd call it growth, unequivocal growth. But the other thing is that we're using their data, and they have a very different situation than we do. They see everybody. In the United States, we're more likely to see a patient when they need to have treatment. So the patient, the 80-year-old that's diagnosed with a really small tumor, might be managed locally until they have growth, and then they might be referred to a larger center, such as House or Mayo or another very large vestibular schwannoma program. And so what we're seeing is different. So we can't say that the behavior of the patients we're seeing with regard to the natural history is the same as the Danish data. It's without question different. And we looked at our referral bias. We looked at people diagnosed in Olmsted County versus people that we referred in. And you can see that the hearing is worse when they're referred in. The tumor size is larger when they're being referred in. And this just reflects referral bias, which we all have at larger centers. So there's these statements that we'll always use in the United States when we're seeing a patient, but frankly, they don't apply to the patients we're seeing very accurately. We'll say that 1/3 of vestibular schwannomas ultimately grow. We'll also say if a tumor hasn't exhibited growth within 5 years of observation, it's unlikely to continue growing. There's actually been some papers that say you don't even need to follow them after 5 years, which I think is a little concerning. And then we'll often say once growth is detected, the tumor is likely to continue to grow, and your outcome is always better when you treat a smaller tumor, so you should probably have it treated now. And I think that's a very conservative and a reasonable statement, but I think there's some evidence to say that maybe we should think about it even a little bit beyond that. So if we look at this is a study we performed at Mayo that looked at volumetric change and linear change, and we compared them. We had 396 patients who were eligible for the study that had, the 396 eligible patients, 361 had at least 2 MRI scans, and over 1,600 MRI scans were looked at. This is Dr. Lees, who did most of the data, so she deserves a significant amount of credit. This is basically why it's potentially beneficial to do volumes instead of just maximal linear dimension. Not all tumors are regular, round, spherical, golf balls. A lot of them have an irregular shape, and some of them are more nodular. And some tumors grow in a craniocaudal dimension and not just in an axial view. And so if you're only getting a single axial view, a single axial diameter, you might miss or under your measures of detecting growth might be less sensitive than volumetrics. A lot of people would counter and say, well, you can't do volumetrics and all your tumors in clinic. It's too time consuming. There's not a good way to do auditive segmentation. I get it, but just from a research standpoint, it's probably, you would get better data from that. But anyways, let's look at our rate of time to detection of linear growth and volumetric growth and time to treatment. Those are three different things. So if you follow a person out long enough, or at 5 years, about half of tumors are treated in our experience who are initially observed. And then about 50 to 60% of them will exhibit linear growth. And if you follow them out long enough, over 80% will demonstrate volumetric growth by about 10 years. And so that's a far cry from they actually quote, I think, 17% for intracanalicular and 30% for CPA tumors growing within the Danish data. So their data is accurate, but for their population, and again, they don't account for IC growth, which I think is an oversight, at least based on how we look at data and growth in the United States. And this is just to say that this is not the Rochester experience. Other people in the United States who have looked at volumetric growth have documented similar findings. That probably, I think a good rule of thumb to think of now is that 50% of tumors grow within the first 5 to 6 years on linear dimension if you embark on an observation. And then what about the other statement that if they don't grow within the first 5 years, they're unlikely to grow later? We found that there are some patients with late growth. It is uncommon. Most do document growth right away, but there are a significant number of people that will still demonstrate delayed growth. People who demonstrate or exhibit delayed growth are more likely to have smaller tumors and have slower growth over time. But this basically leads to our recommendation that patients who are undergoing observation need lifelong follow-up or surveillance unless they're 99 years old and have a 2-millimeter tumor or something like that. Of course, there's exceptions, but as a general rule, we should be doing that. And to give credit to Rob Machelek, one of our residents, he's actually on my service and sitting right next to me right now. He'll be applying to neurotology. He wrote that paper, so credit where credit's due. So this next part goes into, okay, so we're saying that a lot of these tumors are growing over time. What about in my opinion, the real question is, what's the natural history of a growing tumor? Because I think all of us would agree that if your tumor's 3 millimeters and it grew to 5 millimeters, that's not an emergency by any stretch. The only thing it might risk by waiting longer is loss of serviceable hearing, and you lose your opportunity to try to intervene with surgery to preserve that long term. But aside from that, you will not have a difference in facial nerve outcome on a 3-millimeter tumor or a 5-millimeter tumor. Obviously, at some point you will, and we haven't defined that clinically significant growth for microsurgery. But unquestionably, I think that we might be even overreacting on small tumors where you can continue to observe them, particularly somebody who has a small tumor, only hearing ear, or other situations where you might, I know that's a very controversial topic, but those are situations where you might consider observing a tumor that's already growing. So this study looked at a population of patients, almost 100 patients, who had initially a diagnosis of tumor growth, but we elected to continue to observe them. So this is very selected. These tended to be older patients with smaller tumors. About half of the time, we recommended that they have treatment, but they said, I don't want to have treatment. And so against our recommendation, they didn't have treatment. And the other half is a situation where we said, it's probably reasonable for you to continue to observe. But so at time 0 on this Kaplan-Meier plot, everybody had diagnosis of initial tumor growth on their MRI scan. And by about 3 years, half of those tumors did not demonstrate subsequent growth. They were still getting scanned. In fact, we are more likely to scan a person closer if they're exhibiting growth than somebody who hasn't demonstrated growth for 5 or 10 years. And so about half of them didn't continue to grow at that time. If you follow them out long enough, a lot of them did end up growing. But still to say, this shows that tumors have saltatory growth, meaning they can grow and stop and grow and stop. It's not that just once they start growing, they're going to continue to grow. And I didn't need to show you this Kaplan-Meier plot for you to already know that, because we always tell patients about half of tumors don't grow after diagnosis for an extended period of time. But we all think that people weren't born with tumors, so they had to grow at some point to get to that size and stop growing. So we already know the tumors can start and stop intuitively. This just shows growth patterns volumetrically. You can see that some tumors will be stagnant for a while, then all of a sudden take off. Some tumors will grow fast and all of a sudden stop growing, and some tumors will stay steady for a while. And some, depending on what series you look at, about 5% of tumors will actually regress in size or regress in volume. I have land in northern Minnesota, and this is what you might see if you're driving up there, if you get there at the right time. Right by our truck. There's my kids in the back gasping. Big moose. So what about hearing? The natural history of hearing. What if you don't? What if a patient starts with serviceable hearing, which we'll define here, and what happens to their hearing over time? So broadly, some people will say, well, we shouldn't be looking at it so categorically. We should be looking at it more on a continuum, and I agree with that. But just for presenting the data, it is helpful to broadly categorize people into serviceable, not serviceable hearing. And so the general rule for people who are not neurotology fellows or staff, there's a good rule of thumb we call the 50-50 rule. If they have better than 50% word recognition and less than 50 dB PTA, they probably have hearing that could benefit from a hearing aid or naturally, and they have good hearing. And if they have worse than that, they probably have hearing that's not very useful, even with the hearing aid. Again, that's a very coarse rule of thumb, and it doesn't apply to everybody. But if you use those definitions, you'll understand what we're talking about here. So this is a group of people that were observed, approximately over 400 people that were observed who started off with serviceable hearing, and you can track them over time. So to go down in the Kaplan-Meier plot, it was one patient that went from serviceable to non-serviceable hearing. And so at about 5 years, about 40% of people develop non-serviceable hearing, and about 60% retain serviceable hearing. And our data, along with everybody else's data, and probably the people that demonstrated first were the Danes. And it's just that if you start off with a lot better hearing, you're more likely to retain hearing longer, and particularly if you start off with 100% word recognition. So broadly, if you start off with good hearing, you're more likely to retain it longer. This is by Jacob Hunter. This is an awesome table. I think it's really cool. You can take a person. So this is a table that was modeled after 500 patients, that group that we just saw. And you can take this table and you can take your individual patient and you can look at their word recognition score and their PTA, and you can give them the probability of maintaining hearing at 1, 3, 5, 7, and 10 years. So you don't have to broadly say, well, half of people retain hearing at 5 years. You can actually say, for you, your probability of retaining hearing is this much. So it's kind of cool. It's a more personalized counseling. There's another thing I think that's worth looking at. Everyone always kind of stops there. They say, well, the best way to understand if you're going to have good hearing long-term is what you start off with at diagnosis. And they kind of stop there. So it's a static predictor. But intuitively, we'd say, well, if you develop progressive hearing loss at a rate faster than somebody that isn't having that rate of hearing loss, you're more likely to acquire non-serviceable hearing sooner. That's very intuitive, but no one really looked at it that I know of. And so we looked at how the initial rate of hearing loss after diagnosis determines your fate for development of non-serviceable hearing. And intuitively, the data shows what you'd intuitively expect. The more hearing loss you lose up front, the more likely you are to acquire non-serviceable hearing faster compared to people that don't exhibit that first drop. How is this useful? 2 applications. First, you can use it for counseling. You can just tell a patient, you're on a downward trajectory, you're probably going to lose your hearing sooner. And then again, if it's a small tumor and it's favorable and they still have reasonable word recognition, it might be a case you're going to intervene on. They have threatened hearing loss, and you might consider the idea of proactive surgery, moving the tumor to try to protect them from a drop in hearing. Again, a very controversial subject, but at least worth presenting. Key points from this chapter: half of tumors are treated after 5 years, 60% exhibit linear growth. You may have delayed growth after 5 years, so you shouldn't stop surveillance unless there's always exceptions, of course, but in general. And then greater than 40% of tumors demonstrate no subsequent growth at about 5 years after initial growth. And early change in PTA and word recognition score portend change in serviceable hearing almost as strongly as what you start off with. So what about treatment recommendations? I just want to make sure I'm respectful of everyone's time. So we all know that for small to medium-sized tumors, particularly under 2 centimeters, there's 3 reasonable treatment options, and each treatment option might be better for one patient compared to another. And I think our goal is to identify the patient's priorities and their patient-specific factors and identify the most reasonable treatment for them in joint decision-making process. This just looks at trends over time, and this just shows that observation is becoming increasingly utilized. This is from the SEER database. We have another paper coming out right now that just demonstrates that the SEER actually very significantly underreports observation specifically. And so you can take all of these observation numbers, the blue, and probably increase them quite a bit. But the most important story is not when you average all the tumors out, but you look at the group of patients that are really candidates for all three, and that's the 0 to 2 centimeter group. And you can see, particularly in this group, observation is becoming increasingly used. And at least based on surveys of US neurotologists and neurosurgeons that manage vestibular schwannomas, well over half of small tumors are initially managed with observation across the country. This is a really interesting idea, I think. So we always pat ourselves on the back and we say, we have arrived, we've been enlightened, we understand the natural history of vestibular schwannomas. We know that a lot of them don't grow, and so we can continue to watch them, and we pat ourselves on the back. But if you actually look at the prevalence of treatment over time, that means the number of people per population that are treated with a tumor, we actually haven't slowed down at all. We actually are treating more tumors per population than ever before. And that's because the rate at which we're detecting more tumors is going up faster than the rate at which we're willing to become conservative. Said another way, it probably means that we do have some latitude to observe very slowly growing small tumors without a lot of patient harm. The idea is that before the MRI era, there was a significant number of people that had small tumors that went their whole life never knowing about it and being all the better off not knowing about it. And we would say they needed treatment, and sometimes we would do them a disservice by treating them just because we didn't know the natural history. But this is just to say that maybe we can even be more conservative than we actually are right now. I don't know if you can grab that. It's pound 82445. This just further emphasizes that point. If we follow people over time, again, we pat ourselves on the back, being more conservative. In Rochester, we do observe a very significant number of tumors initially, small tumors, and in our population, you compare what we treated in 1966 to present, the average tumor size at treatment is actually reduced. So we're treating smaller tumors than we used to. The symptoms are less severe, and they're more likely to be IEC tumors compared to CPA tumors. A lot of that reflects selection bias, and the pre-MRI, the tumors were larger at diagnosis, but it just says in a different way that we're still probably have room to be more conservative. It would be a reasonable thought, at least. There's a lot of controversies regarding treatment. There's a lot of different things that push us in an operative versus non-operative direction. People who are more likely to receive a non-operative intervention might be have poorer health, only hearing ear, asymptomatic, older age, smaller tumor, et cetera. And the things that would push us towards operative management, at least historically, would be a more aggressive behavior, macrocystic, rapid growth, large tumor, hydrocephalus, trigeminal neuralgia, ongoing dizziness, maybe controversial. But those are kind of the intuitive, the things that we've always used in the past to help direct treatment. Unfortunately, there's been no prospective randomized controlled double-blinded study in vestibular schwannoma, and it's primarily because patients are not willing to remit their treatment to chance. And us as providers oftentimes really do believe that one treatment probably is in their better interest. It's a relatively uncommon condition. I won't call it rare based on what we've already talked about. It's a heterogeneous disease. No two patients are the same, both from a tumor characteristics, but also what their goals are. There's ethical considerations to randomization. There's innumerable treatment pathways. It's not just microsurgery, radiosurgery, or observation. It's if you observe, and they grow, do you do microsurgery, do you radiosurgery? If you do microsurgery, do you do middle fossa, translab, retrosig? If you do radiosurgery, do you use a Linac, CyberKnife, Gamma Knife, IMRT, proton beam, how many fractions, hypofractionation, conventional fractionation? There's a billion ways you can think about it. And then if it recurs, how do you treat it? Do you do upfront radiosurgery after leaving residual, or do you wait to see if it grows? Do you do repeat microsurgery? Do you do radiosurgery? What kind of dose do you do? So it's not just this, you do one of the three things. You can do one of like 50 things. And so that becomes even more difficult to study because it's heterogeneous. There's also publication bias. People want to publish good outcomes. If you're not doing well, you usually don't publish all of your outcomes in general. And then what outcomes do you even look at? We always look at recurrence-free survival, time to non-serviceable hearing, and facial nerve outcomes, because those are easy to study. But a lot of times patients prioritize different outcomes. How dizzy are they? How incapacitated are they by their headaches? What sort of anxiety are they having just from having a tumor in their head? All these sorts of things that are less tangible, less difficult to study, but still influence patients significantly. And so based on the current evidence and recommendations, we really don't have a lot to stand on. And so we're kind of left with our current data, which isn't very strong. And not to knock just, neurotology broadly, that's otolaryngology and neurosurgery in most or a lot of medicine. When a patient has a very small tumor, or a person with a very large tumor, young patient, very large tumor, hydrocephalus, there's only one obvious treatment pathway that most people would agree on, at least initially. It would be surgery. Of course, you could do, that you could do gross, total, subtotal, and all that conversation, but you would start with microsurgery. But for people with really small tumors, there really might be 2 or 3 reasonable treatment pathways that a patient that could be reasonable for the patient. And what's best for one patient might not be the best for another patient. This is just a general algorithm that we use when we see a patient. And there, you'll see that there's intentional overlap in the 1 to 2 centimeter and 1.5 to 3. There's always overlap in medicine. We like to make things, black and white, but in reality, nothing's really that way. So in general, for a tumor less than 1.5 centimeters, we'll start with observation. If there's growth, we'll recommend active treatment. If there's no growth, we usually continue to observe. If they have a tumor that's between 1.5 and 3 centimeters, we recommend active treatment. And that is microsurgery, radiosurgery, so upfront without observing it usually. And again, this graph or this algorithm isn't perfect. We usually don't do radiosurgery for something larger than 2.5 centimeters just because of the increased risk of adverse radiation effect, trigeminal symptoms, hydrocephalus, transient tumor swell, etc. And then if it's over 3 centimeters, we almost always recommend microsurgery for treatment. And importantly, when we're talking about tumor sizes, we're talking largest axial dimension of the CPA, not counting the IC portion of the tumor, which is important because they're obviously very different. That's just our general algorithm. When we look at what drives a patient decision-making, if you ask a patient, why did you choose the treatment you did for when you had all 3 options for a smaller tumor, patients will say, well, it's what the physician recommended. That's the most common reason. But then after that, people chose radiosurgery or observation because they were less invasive, or they felt their condition wasn't severe enough to warrant an intervention. And interestingly, the most common reason people chose microsurgery, at least in our series, was from a psychological standpoint, they gained relief from knowing the tumor was out of their head. There are some patients that maybe they have a history of cancer of something else, and they say, I know this isn't cancer. You're telling me it's a benign tumor, but I just have this idea of having it in my head, and I just want it gone. And so we kind of say that this is a very small group of people, but I think it's actually a little bit more common than what we perceive. There also is differences in geographical differences. So like if you're in one area, you're more likely to receive one treatment compared to a different area. And this isn't to point any specific center out. This is the SEER database. And so these are the only data that we have. It's not that I didn't want to put Rochester in there. But if you're at one center or one location, you're more likely to get microsurgery. And if you're at a different location, you might be more likely to get observation. And you might say, well, it's because there's selection bias. Certain areas are seeing larger tumors to begin with. But even after you account for age and tumor size, these certain centers or these certain locations, I should say, are more likely to do one treatment compared to others. But what about looking at quality of life over time? We've already said that historically we've prioritized hearing outcomes, tumor recurrence, and facial nerve outcomes, but increasingly we're recognizing that there are other patient-reported outcome measures that are very important to also consider. Historically, we've used the SF-36, which asks generic questions about quality of life, like can you carry groceries up the steps, which have nothing to do with a patient with a sporadic vestibular schwannoma. And so naturally, you can see how these measures would be not sensitive to change within a patient with a vestibular schwannoma. So fortunately, a disease-specific measure, the PanQual, was developed in 2010, which has 7 domains and looks at areas that are more specific to patients with vestibular schwannoma. Using the PanQual, we looked at approximately 500 patients and normal controls, and we compared cross-sectionally differences in outcomes. And I want to make a couple points. First of all, this does not include baseline features. We did perform in a multivariate analysis. We tried to control for differences in baseline features, but there is selection bias. It wasn't randomized, and we don't actually, in this one, it's cross-section. We don't have what their baseline score was, so it's not perfect, but it's decent. This basically just shows the biggest quality of life reduction comes from the diagnosis itself. So the blue is people without vestibular schwannomas. So your in general, your disease specific quality of life for vestibular schwannoma is better if you don't have one, which is intuitive, but it does tell you that the measure is probably at least reasonably sensitive to the disease, which is important in contrast SF36 and Glasgow benefit inventory. But just a couple other things. In most situations, the differences between the treatment arms are very, very small. And there's something called the minimum clinically important difference. That's the smallest difference between two scores that the patient would think actually matters and what we might use to help us determine decision making. And in other words, we don't think on a 100-point scale, like the PanQual has 100 points, if you change from 50 to 51, we don't think that probably matters. Or maybe if you change from 50 to 52, it probably doesn't really matter. But at some point it does. So where is that tipping point where it actually matters clinically? And as a general rule of thumb, if it's more than 10 points on the PanQual or 7 points on the SF36, it probably does, it's clinically significant. So when you're looking at these studies, you shouldn't just look at the p-value, because if you have a study with 1,000 patients, you're going to get tons of highly statistically significant data, but it often might not be clinically relevant because there are only 1 or 2 point differences. So you need to look at both. And all that to say, when you apply the MCID to all these very small differences, it's basically almost a wash. So as long as you're giving your patient a reasonable treatment and you're giving good care, there actually isn't a huge difference in quality of life outcomes between the 3 treatment modalities. This is a prospective study. The last study was cross-sectional. This is a prospective study of approximately 250 patients. So we followed them from baseline and through their treatments, and we saw how they changed over time. And a couple things I want to point out. The main thing I want to point out is when you take a group of patients before surgery or radiosurgery observation, you follow them over time, the mean change after the treatment is less than 1 point on a 100-point scale. That means to me that the patient themselves predict how they're going to do much more than our treatment, as long as we're not botching it, as long as we're doing a reasonable job for them. So patient-specific factors, how they perceive life, how likely they are to be satisfied just inherently, all these other things predict their outcome almost more than the treatment, as long as you're giving reasonable treatment. There is an interesting phenomenon, though. When you looked at everything, the only area that was statistically significant and clinically significant based on that MCID for change was anxiety improvement in the microsurgery group. So there might be some benefit, going back to that whole idea, a small percentage of patients actually have an improvement in anxiety, knowing their tumor has been physically removed and gone. Again, going back to the idea that's the only one that actually provides true cure. This is another important concept I think that we should think about. This study is a little different than the other studies in that it also includes an arm of patients who are just diagnosed. So we called these the less than 6 months. They haven't had treatment yet. They don't know what treatment they're going to have. So they're early at the beginning. And then the other groups are observation comprised people that didn't have treatment that were over 6 months, and then radiosurgery, microsurgery, multimodality therapy. And the interesting thing is the only group, so what this shows you is the nadir of a person's anxiety on their whole journey with the vestibular schwannoma is at diagnosis. So they were just told they have a brain tumor, even though we're saying it's benign and often small. That imparts a significant quality of life reduction, at least from an anxiety domain. And it probably is better for the patient in some situations to think about it a little bit and not just have immediate treatment. And the idea is they can, if they sit on it a little bit, they can understand it's not going to kill them. They can make probably a more calculated decision, and they're not making a decision driven by some level of anxiety to just have the tumor out or something else like that. It also builds rapport with you and the patient. They understand that you're trying to help them and not just give them an immediate treatment. There's a lot more to that decision making, but I just want to present the idea that patients might be in a more anxious state initially at diagnosis, and they might be less likely to make a strongly logical decision than if they were able to think about their options for a little bit longer and also characterize growth. So like if they get a scan at time 0 and 6 months and it hasn't grown, that informs their decision making even more than just having treatment up front. This is the last thing in this group of studies that I want to show. This one's not out yet. It was just accepted, or it's under revision, but it's coming out soon. But this just presents the idea of, so some patients will come into a situation, they'll say, okay, I realize I have all 3 treatment options, but I'm really afraid of getting really bad headaches. That's the one thing that's going to drive my decision making. which treatments most are least likely to give me bad headaches. Or they might say, I really don't want facial paralysis. Which one's least likely to give me facial paralysis? Or they might say, I have really bad headaches now. Which one's most likely to improve them or least likely to make them worse? And sometimes those outlier symptoms drive decision making for select patients. And so we looked at we looked at this question. This is based on a Likert scale, 1 to 10 ordinal scale. So 1 being most mild symptom or non-existent, and 10 being the worst of that symptom possible. So 10 out of 10 is the worst headache of their life, and 1 is non-existent headache. So this in this study, we looked at patients and how they changed. This is prospective longitudinal. We compared their baseline score before treatment to afterwards, and we saw how patients changed. We defined a clinically important change as at least 2 points on a 10-point scale, and there is data to support that designation. And so if you look at this, so I didn't highlight hearing and facial nerve paralysis. It's a no-brainer that technically, most people think that you're more likely to acquire hearing loss sooner if you have surgery compared to other things. And again, that varies broadly by size and everything else, but broadly, if you operate on everybody, you're more likely to lose hearing earlier than if you don't. And same with facial paralysis. You have a higher rate of facial paralysis with surgery when you take all patients compared to observing or something else, at least in the short term. So I didn't highlight those because those are no-brainers. I think we can all agree on those. But there are some interesting things that came out of this. So headaches were interesting. You were more likely to you had a higher chance of having clinically significantly worsening headaches or a clinically significant improvement in headaches. And maybe that's the law of proportionality, meaning anything that, the degree to which something can cause good is also equal to the degree in which it can cause harm. It's a more invasive treatment. Even when you do it well, it's a surgery nonetheless. And so interestingly, some people actually improved with their headaches. And maybe that's the group with concomitant trigeminal neuralgia or hydrocephalus with headache, et cetera. But interestingly, it can go both directions for headache. But what about when you took the group of people with the worst symptoms at baseline and they were trying to get better? Or if you took people who had no problem with it, are they more likely to get worse? So the previous slide just showed everybody. But this shows that technically you have a higher incidence or higher risk of having headaches, at least in the short term, according to the study with surgery. It's not a large number more, but is statistically significant. And unfortunately, so this is a very interesting slide. I know this will be controversial, but unfortunately, if you have really, really bad headaches or really, really bad dizziness or really, really bad tinnitus, none of the treatments reliably make one of those symptoms better compared to the others. I know historically we'd say dizziness is better for microsurgery, and it might be true for the patients who have that unstable vertigo that comes and goes. But for the person who has symptoms of vestibular hypofunction and other concomitant dizzy conditions, and they aren't compensating well, operating on those patients usually don't make them better. So some key points: small, medium-sized tumors. There's no unequivocal evidence to say one's always better than the other. There may be an underappreciated benefit of surgical cure in some patients, and I'm not sure we're really being more conservative now than we have been in the past. This is just a shameless plug for a educational. This is not affiliated with any site. It's a national collaborative for education. Headmere.com. We have a lot of. I'm part of the team. There's a very big team that's involved in this, but we have a ton of podcasts. I think we have about 130 out right now. We have a ton of we have a ton of surgical videos that are narrated, I think, very good, not just neurotology, but across all fields. You have about 100 videos there. And it's been a fun thing to work on. And if you haven't heard of it, I encourage you to look at it. This is the extended team of people involved, primarily the podcast, but also videos. And there's a lot of other stuff on the site that you might benefit, particularly trainees. So that's everything. Hopefully I didn't go over.